to atrial fibrillation for the non-specialist. So I'm going to present two quick cases, and then I'm going to talk to you about how you manage atrial fibrillation, and hopefully these cases will cover the sort of broad spectrum of what we might expect to see. So our first customer is Mrs. Fractured Knopf. She has a background of being able to walk about 200 meters slowly with a stick. And she's a bit overweight with BMI of 35 and diabetes type 2. And yesterday she fell, broke her hip, and got surgery. And now, first thing in the morning, you are called to see her as the junior doctor working in Ortho Jerry's, because the patient's developed acute shortness of breath, palpitations, and chest tightness. And their blood pressure's good, but their SATs are about 95% on air. And they've got this ECG. And I hope everybody can agree with me that this is an irregular rhythm, and it's tachycardic. And what does everybody think the rate is on this ECG?
Around 150.
Yeah, it's about 150. So that's your background. What are you going to do about it? So this lady has got fast atrial fibrillation rate of about 150. So could think about pain relief. Yeah, maybe this lady's in pain and that's why she's tachycardic. You can certainly do your A2E. The fact that she's complaining of palpitations and chest tightness probably means that she's managing most of her A2E, but you can certainly approach it like that if you'd like. You can't go too far wrong approaching an emergency like this, although is this an emergency? We're not really sure yet. So maybe it's just pain driving the rate. Any other things to think about here? Concerns of an embolus. So we could have a pulmonary embolism. Yeah, absolutely high risk patient. We could have a fat embolism. What are the symptoms of a fat embolism?
Rash, anuria, purpuric rash mainly, anuria as well.
Yeah. So rash, petechial or purpuric rash, and anuria. You can get an ARDS with it. You can get confusion and cerebral sort of symptoms of agitation, seizures. And you could also get fast atrial fibrillation with it. So absolutely, thank you, Emmanuel. So an embolism we need to think about. Anything else?
Sepsis.
Sepsis, absolutely. So maybe this patient has got sepsis, chest infection, urinary tract infection. Maybe they've got infection in their brand new hip screw. Any other things that you're going to be thinking about and considering in deciding how to manage this lady? So this is the kind of case that our registrars get phoned about on a daily basis. And here the example is a fractured neck of femur, but it could be any patient in hospital who suddenly then becomes unwell with fast atrial fibrillation. Yeah, bleeding, absolutely. So she could have either severe anemia caused by the bleed from the hip fracture and the surgery, or she could have new hemorrhage causing her to become tachycardic. So with respect to the atrial fibrillation itself, are there any additional questions that we're going to want to ask ourselves? Good, we want to see a previous ECG. So, and is she known to have atrial fibrillation? So what does everybody think? Do we think she's known to have atrial fibrillation, if you're guessing?
No, this is likely to be new AF.
Yeah, it's likely to be new. I mean, it's possible either that she's had some stress causing her to develop fast AF, whereas normally she has controlled rate AF, but more likely than not, she's suddenly gone into AF to explain this acute change in presentation. But it's a key question, because if she's known to have atrial fibrillation, she's not got any good reason to suddenly be going fast from a cardiac point of view. So if she is known to have atrial fibrillation, then unless we've been admitting her beta blockers or other rate control medications, then it's not the atrial fibrillation that's the problem. But here it's likely that it's the stress of the surgery has put her into atrial fibrillation. Stress of any description can cause you to go into atrial fibrillation. It tends to be that you have an underlying tendency to go into atrial fibrillation. So it's that plus some underlying substrate that means that it happens. If you went into atrial fibrillation when you had a minor operation or a chest infection, then I would not just say, oh, it was the stress of the chest infection causing it. I'd want to look a little bit deeper to see why it happened in you. But this lady at 80 years old and with raised BMI and diabetes is clearly a high risk of this sort of thing happening. So we're not surprised at all. But we should absolutely look to see what could be driving the underlying rate here. Rate of 150 isn't that fast. We're not particularly concerned about this lady running along at 150 for the next day or two. Obviously, she's complaining of palpitations. She's not particularly happy, so that would be a reason to try and slow things down. But we're not worried about the rate itself causing harm. We would want to see if she's developing heart failure because of it. These SATs of 95%, why are they low? Is it because she's just had surgery and she's spent a lot of time lying flat? Maybe it's because of that combined with the obesity, or maybe she's going into pulmonary edema. The AF itself wouldn't necessarily be doing that, but it might be that she's got heart failure, which has put her into atrial fibrillation, and she has had it exposed by the fact that she's acutely unwell. So don't just think fast atrial fibrillation, think why it might be happening. But assuming we rule out all these other things, how are we going to treat this patient?
Chemically cardiovert her with metoprolol and see how it goes. Her blood pressure is tolerable for beta blockers.
So you said chemically cardiovert there. Is that what you meant?
Yeah, just a trial of metoprolol and see how it goes, provided that we have included all the other causes of AF.
So beta blockers have limited effect in terms of cardioversion, but they would be a good choice of medication for rate control. So we could give some IV metoprolol. In fact, just some oral bisoprolol would be fine here, or oral metoprolol would be fine here. The main thing we're wanting to do is to slow her rate down below about 120 and ideally below 100. So rate control the patient. Absolutely. Is that the most important thing you do for her? So we treat the cause, but assuming we've decided it's just the stress of the surgery, so anticoagulation is the most important thing that we do for her, because it may be that she's stressed because she's discovered she's got atrial fibrillation, and it's that the sort of awareness of palpitations is making her anxious. Lots of adrenaline in her system. When you're in AF, often you get an inappropriately fast pulse rate with stress and with exercise. Maybe that's why she's running so fast. She just needs to be told everything's okay, everything will calm down. But if you don't anticoagulate her and she has a stroke, then it will be very hard to defend why you didn't consider anticoagulation. Now, here, the recent surgery might be a problem. That needs to be discussed with the orthopedic team, but anticoagulation needs to be considered for every patient in atrial fibrillation. Now, I'm not saying every patient gets anticoagulation, I'm just saying it must be considered. So rate control with a beta blocker and anticoagulate. In the longer run, this patient is unlikely to sustain sinus rhythm. So we could think about cardioverting. It is less than 48 hours. This has just been pointed out on the chat. Thank you. So we could think about a cardioversion, but the chances of that having long-term success are low, and it comes down then to symptoms. So I'll come back to that point in a minute. So just been asked, is prophylactic low molecular weight heparin suitable for anticoagulation? So that's a great question, and the answer is absolutely unequivocally not. So if you give somebody DVT prophylaxis, low molecular weight heparin, as prophylaxis of their atrial fibrillation, you are not properly anticoagulating the patient. So it needs to be treatment dose if you judge that the risks of bleeding are low enough to be able to start that. So we could either, depending upon what the orthopedic team said, start her on a DOAC, which would work very fast and we wouldn't need to give heparin, or else we could start her on heparin and then think about what we did in the longer run, but it would be treatment dose heparin. So quick further case, and then we'll come back to how we manage atrial fibrillation. This chap is this time called Mr. Atrial Fibrillation because he's trying to make your diagnostic life easy. He's 59 and he's been referred by his GP with recent onset atrial fibrillation. So what are you going to ask him in terms of his symptoms? So what questions are you asking a patient with atrial fibrillation? So how recent was the onset? So the longer you're in atrial fibrillation for, the harder it is to get the patient out of it, because while they're in AF, changes are happening in the heart that mean you'll have more atrial fibrillation. So you want to know, was it a week ago? Was it 48 hours ago? Was it 6 months ago? If it's been over a year ago, then the chances of getting him out of it are very low. So here, for the sake of argument, let's say 3 months ago. Good. So what was the onset? Next question is it constant or paroxysmal? So yes, so you would ask, are the symptoms episodic? Sometimes patients will tell you that they have breathlessness that has been coming and going. So they might have a morning where they couldn't go for a walk because they were too breathless, but they felt fine in the afternoon. And this has been coming and going for months, and then it got bad all the time. So the next question is there syncope or dizziness? So atrial fibrillation doesn't tend to cause syncope or dizziness. It might, when you go from atrial fibrillation back into sinus rhythm, sometimes the sinus node has been asleep while you've been in atrial fibrillation, so there is a risk of a termination pause. So when the atrial fibrillation terminates, sometimes the heart pauses for a second or two while the sinus node wakes up. So that can cause syncope, but fast atrial fibrillation doesn't cause syncope, and atrial fibrillation itself wouldn't typically make you feel particularly dizzy. So exercise tolerance or exertional breathlessness is certainly an important question. So ask about how fit and active the patient is, how much regular exercise they do, and what's happened to their exercise tolerance. Good. Any other questions? About symptoms? So the most common symptom that people tend to describe is fatigue. So the presence of fatigue, it's obviously a very non-specific symptom, but that's what patients probably most commonly, fatigue and malaise, they get when they're very symptomatic from the atrial fibrillation. That, together with the exertional breathlessness, which from our point of view is the one that is most useful because that's a harder symptom. Don't tend to ask much about palpitations. If I want to know if it's paroxysmal or not, I might, but it's not very often that people complain of palpitations as a major part of their symptoms when they're referred to as with atrial fibrillation. And we've covered episodic and how long the symptoms have been there for. So our other key questions, yep, we want to know a bit about the past medical history for CHA2DS2-VASc scoring, very good. But sticking with the sort of questions that are going to help us with Well, I'll scratch that. So what other questions are going to help us with the management of this patient's atrial fibrillation? So what other questions and assessments are we going to do? So does anybody know any bleeding risks? Yep, we should ask about bleeding risk. Good. Does anybody know what factors mean that you are going to struggle to control this patient's atrial fibrillation, to struggle to rhythm control them as opposed to rate control him?
Age, how chronic it is.
Yeah, so age is a difficult one because as you get older, you tend to acquire more risk factors, or you tend to have been in atrial fibrillation for longer. But you certainly want to need to know how chronic the atrial fibrillation is. So the ischemic heart disease isn't particularly helpful. I mean, it's obviously something you'll ask, but it doesn't really change necessarily what we would do. So the big ones are obesity. So obesity is a really major factor in development of atrial fibrillation. And we know from studies that if patients lose weight, they're much more likely to stay out of atrial fibrillation. So that's a really important consideration. Other big ones are blood pressure, alcohol intake, and we've already talked a bit about factors to determine CHA2DS2-VASc score. So we certainly want to know about concurrent medications. We want to know, is he anticoagulated? Is his blood pressure well controlled with multiple blood pressure agents? So we could certainly go through that, but there, for sake of argument in this case, there isn't anything that particularly crucial. So this is the patient's ECG. Is everybody happy that that shows that he's in atrial fibrillation, or does anybody want to say, hang on a sec, look, that's a P wave over here. And look, there's another one there. And here's one here. There's one there. There's one over here. Actually, maybe we should map this out. And this is sinus rhythm, and it's a sinus arrhythmia or atrial ectopy causing an appearance of an irregular rhythm. Or is everybody just happy this is atrial fibrillation? Ooh, nobody's prepared to come off the fence. Have I just confused you all? I've just been pointing out bits that look like they might be P waves, but if you look, the morphology of this changes each time. And here, the PR interval is much too short for that to be physiological. So you very often can do that in an atrial fibrillation ECG, but this is irregular, and is definitely atrial fibrillation. So there's no trick here. This is just atrial fibrillation, and this is just the variability in the baseline, which at this particular point happens to look a bit like a P wave. So management of atrial fibrillation. There are 5 key points to how you manage atrial fibrillation. This is the bit to remember, because the first case, it's all about being a good clinician rather than knowing much about atrial fibrillation. The second case becomes they've been referred for specialist assessment of what we should do about rhythm control, and we've detected major factors in his past medical history that mean that keeping him out of atrial fibrillation are going to be extremely difficult. So if he wants us to keep him out of atrial fibrillation, he's going to need to lose weight. He's going to need to accept that his wine cellar full of wonderful highly expensive Burgundy wines is going to have to be passed on to somebody else, because if he wants to stay out of atrial fibrillation, he's going to have to become teetotal. And so we need to make a decision with the patient. We can obviously, we can't insist that he becomes teetotal before we do anything further, but realistically, if he wants us to have success, he's going to have to look at all these different aspects. And so it's a question of just how significant are the symptoms that we want to try and pursue a normal rhythm. Because if we don't pursue a normal heart rhythm, we can obviously give him good lifestyle advice generally, because all of these things would really benefit him in the long run if he addressed them. But rate control has already been achieved, and we can simply say, forget about it, take your meds, and off you go. So restoring sinus rhythm here is going to be a real uphill struggle, even though it's recent onset atrial fibrillation. And if we're going to attempt that, we've got to address lots and lots of different factors. So management of atrial fibrillation, absolute #1 priority is to anticoagulate. That is what is going to make a difference to the patient's prognosis. So CHADS-VASc and HAS-BLED, I'll show the scales later on in this presentation. It's entirely reasonable to say we should not anticoagulate this patient because their risk of bleeding outweighs the benefits. But that is the kind of statement that you need to be writing down. It's the risk outweighs the benefits. And that has to be assessed on every patient with atrial fibrillation. And even if if you've got lone AF with the CHADS-VASc score of 0, then in that situation, the risk of anticoagulation still outweighs the benefits. So that statement holds good basically for all patients, that you're not going to anticoagulate. We then want to rate control patients, and we want to rate control probably to a rate of about 90 or lower. And we've done research studies which show actually fairly loose rate control of rates of 110 are fine, and actually patients feel worse if we more tightly control them than that fast rate. I'd feel a bit queasy letting somebody wander around permanently with a heart rate of 110, but certainly I wouldn't seek to get it below around 80 to 90, and I would use a beta blocker for that. So the beta blocker is definitely the first line medication, because when patients exercise, the adrenaline they produce can make your rate go much too fast, and so beta blockers are very good at damping that down. If you use digoxin, you might control the rate at rest, but then it goes out of control with exercise. If the beta blocker is not working, or if it's contraindicated because they've got severe brittle asthma, then a calcium channel blocker, which is rate limiting, like diltiazem, would be entirely reasonable. And you can combine the two. So if you have a young patient with a slick, healthy AV node that's able to hear all the sort of, even the big and the little whisperings of the atrial fibrillation hurtling around in the atrium, then you get a fast heart rate. If you have an elderly patient, usually the heart rate's slower, although lots of people, AV nodes, are quite happy conducting at a rate of 150, so elderly patients may well be fast, but a young person might have a rate of 200 and be desperately symptomatic because of the very fast rate when they're in atrial fibrillation. If you're having to use a beta blocker and a calcium channel blocker, then you increase the risk of the patient going into complete heart block, particularly if they're elderly. So sometimes we end up, or it's not sometimes, a very common reason for a pacemaker is if you end up in tachybrady syndrome. That is, that you're tachy when you're in AF, you go back into sinus rhythm and you go slowly. And so a pacemaker to stop your heart going too slowly, and beta blockers or combination of medications to stop it going too fast is a good way of managing it if you need to. Obviously, patients prefer not to have pacemakers if they can help it. I've been asked the question on the chat, what if it's only once a year? Doesn't matter. Doesn't matter if they've had their first episode of atrial fibrillation. if they've got the substrate to get it again, then them going back into atrial fibrillation is going to mean that they're at risk of having a stroke. So if their chance VAS score is appropriate for anticoagulation, unless you're very confident they're not going to get it again, they should be anticoagulated. So by very confident, if the patient has got a normal heart, say a chance VAS score of 2, and has gone into AF with a severe pneumonia, and you've cardioverted them and they've been free of atrial fibrillation for 6 weeks, you'd be pretty confident that they're not going to get atrial fibrillation again. Their chance VAS score isn't that high, so fine. You might not want to anticoagulate them, but or long term, but most patients need long-term anticoagulation, irrespective of rhythm control. The third point is that we need to do an echocardiogram. Now, you can argue this a little bit, but the bottom line here is that why has the patient gone into atrial fibrillation? Is it that they've got an undiagnosed heart condition and that has created the substrate for the atrial fibrillation? So maybe they've got mitral regurgitation and you've not heard it, or aortic stenosis, or an atrial septal defect that you really wouldn't hear the murmur. These are things that could, the atrial fibrillation could be the first sign of. So I would want an echocardiogram in all my patients with atrial fibrillation. Even if they're a young person who's been binge drinking alcohol and have gone into atrial fibrillation from binge drinking, well, maybe they've caused themselves an alcoholic cardiomyopathy, and that's why they've gone into atrial fibrillation rather than it just being the arrhythmic effect of the atrial fibrillation per se. So echocardiogram. Point 4. Lifestyle factors. So addressing the lifestyle factors is really important, both for longer term prognosis, but also if we want to keep patients out of atrial fibrillation, we need to address lifestyle factors. But from your point of view, you're thinking rhythm control of the atrial fibrillation. You're thinking rate control. You just want to slow the patient's heart down and then look at addressing things like lifestyle factors, because usually atrial fibrillation is a sign that they're not particularly healthy for some reason or another. And then point 5, at this point, if the patient has ongoing symptoms, you can refer to see a specialist for help. So you don't need to refer the patient for anything further, providing they are asymptomatic. The caveat to that is if you've got a very young person, they're probably outside of the trials. So if they're in their 50s and they don't have lots of adverse lifestyle factors, even if they didn't have ongoing symptoms, I might want to see that patient to assess them. But if they are symptomatically well and they don't have, you're not, they're in any way getting over the age of, say, I wouldn't have a strict cutoff, but say over 70, or they've got major lifestyle factors driving the atrial fibrillation, then that patient rate control is absolutely fine. We do not need to try and cardiovert them back to sinus rhythm. Now, sometimes you're not sure if they have symptoms or not. Maybe they're pretty slowed up, but they've been pretty slowed up for a little while and they're not sure if it's just they're getting older. Sometimes we could do a cardioversion to find out, but that does involve quite a bit of messing the patient around, and it tends to involve drugs like Amiodarone, which have got potentially quite a lot of toxic side effects. So does everybody know the side effects of Amiodarone? So amiodarone can cause life-threatening lung or liver damage. It can cause peripheral neuropathy, photosensitivity, they sunburn very easily, and it can cause hyper or hypothyroidism. And it also can cause blurry vision, particularly at night. That's a reversible problem, but the life-threatening lung and liver damage aren't necessarily. So it's a pretty toxic drug. About 15% of patients don't tolerate it, but very few actually develop the really serious side effects, and that tends to be long term. But we'd probably need to use that in order to successfully cardiovert our 59-year-old example here. We might give it him for 3 months before a cardioversion and then for 6 months afterwards to see if it sticks him in sinus rhythm. And at that point, we might even continue it longer term if he feels much better for it. And if patients have severe symptoms, we absolutely want to try and address those symptoms. And it may be worth any amount of treatment because he feels so rubbish in the atrial fibrillation. But most patients, once they're rate controlled, are not particularly symptomatic, and for them it's absolutely reasonable just to manage them with rate control and beta blockers. Patients like this 80-year-old who's got new onset AF, you might say, well, she's just developed it, so why don't we try cardioverting her and maybe she'll stay in a sinus rhythm. But what have we gained by doing that? If she's symptomatic after we've rate controlled her, then maybe, but she will end up back in atrial fibrillation, or else we will have to give her lots of toxic drugs, which it generally speaking would be better just to manage her with rate control. Many patients spontaneously cardiovert in the first 48 hours or even first week or two. So very often, if there's something driving the atrial fibrillation, they'll cardiovert spontaneously. NICE have given guidelines on AF management, and this presentation is very much follows what NICE guidance says. I'm not sort of some maverick talking out of turn. This is NICE guidance really, which I'm summarizing for you. If the patient gets sent to us, we can do the cardioversion we've talked about, and the other thing is we can do an AF ablation. And an AF ablation involves putting tubes up through the femoral veins into the heart. It takes about, depending upon how sophisticated they make it, between 2 and 4 hours. It's not particularly pleasant. It can be quite painful having bits of the heart burnt while you're awake or sedated. And there is a significant risk associated with it. This is a big American real-world analysis which found almost 1 in 200 mortality rate after AF ablation within the first month or so of AF ablation. So it's not a low-risk, simple procedure to offer to everyone who has a bit of atrial fibrillation. It is there for patients who have severe symptoms, and if we're not sure if the AF is causing their symptoms, doing the cardioversion can be a helpful way of assessing that. Why do we have this approach? Well, the AFFIRM paper from 2002 was the big trial which showed us that patients do just as well with rate control as they do with rhythm control. So that's the basis for all of this. And ever since this trial has come out, doctors have been trying to show that actually patients do better after all with AF rhythm control and AF ablation, and nothing has ever shown what I would consider to be significant benefit. So we can be confident on the basis of this trial and the fact that thousands of people have tried to show benefit and haven't. A couple of other trials I'll show you now, there's bits to be aware of. What about our patient that falls frequently? Should we deny them anticoagulation? Well, this is a trial looking at patients judged to be at high risk of falls versus those judged to be at low risk of falls and showing no difference in risk of bleeding. Now, just be aware that you need to look beyond the soundbite when assessing research, and this cohort of patients is patients being discharged from hospital, and they're patients who are being treated with anticoagulation being discharged from hospital. And so the doctor had to judge them appropriate for anticoagulation despite their high risk of falls in order for the patient to enter this trial. So just, and it's not a proper research trial, it's a registry. So this I would take to mean that if you think a patient ought to be anticoagulated despite the fact that they are a relatively high risk of falls, then you should anticoagulate them. It's not carte blanche just to ignore any risk of falls and anticoagulate. I talked about the need to stop drinking alcohol. This is a wonderful study from Australia. It's kind of thing I wish I'd done when I was a registrar. If I'd been really clever, I would have done, because this is a New England Journal paper and they've just got 140 patients in it. I mean, I could have recruited 140 patients and asked them to stop drinking. This showed that if you did this, the rate of atrial fibrillation recurrence in the abstinent group was 50% versus 70% in the control group. So you can see not everybody gets atrial fibrillation back again, but a lot of people do either way. But it's a big reduction in risk. You might say, well, I love my fine French wines or my wonderful Scottish whiskey. And I don't think this is enough of a reduction to be worth giving up something I love, and that's the choice the patient makes. This is a trial called Cabana. This was a really important trial because it was a big multi-center study, 2,000 patients, looking to see if AF ablation improved prognosis. Because if it did, then suddenly we would need to do AF ablation on everyone with atrial fibrillation, symptoms or not. But here, it reduced the rate of recurrence from 70% down to 50%. So exactly the same numbers as this trial of alcohol cessation. So patient would do his health good cutting out alcohol, just as effective at reducing his recurrence of atrial fibrillation as doing the AF ablation would be. And just bear in mind that this is alcohol who consume 10 or more standard drinks, and this is there's slightly different parameters in Australia, but this is basically 14 units a week. So this is they drink 14 or more units a week. It's not alcoholics. This bit of it's missing off the slide. This is a paper called East AFnet, and this came out in 2020 and is potentially being used as a reason to completely change clinical practice, and rather than use rate control, go to rhythm control. And I think that's completely wrong. But this trial is out there and would potentially be against what I've been saying in this talk, which is why I bring it up. Sorry that this is off the page slightly. Let me just see if I can move that back. And so can you see the slide now? And so this found that if you had rhythm control, your first primary outcome, which is a composite of death, which is clearly very important, stroke, which is obviously important, but a bit softer, and then much softer hospitalization with worsening heart failure or acute coronary syndrome. The first primary event, you got it in rhythm control in 4 per 100 patient years versus rate control 5 per 100 patient years. So, one event per 100 person years, that's a difference. It's not very big, but it's there. But if you look at the serious adverse events related to rhythm control, it was 5% of those patients versus just 1.4% of patients assigned to usual care. So there's a substantial risk attached to more aggressive therapy. And actually, if we look at this group of patients who are about 70, they were being treated with flecainide. And in fact, I think they were slightly older than 70. Does it say in this abstract? I think they were closer to 80. And flecainide is a drug that does put you at risk of ventricular arrhythmias, and it's not a drug to just sort of use without thinking about it. So these patients are potentially being quite aggressively treated with medications rather than an AF ablation. I said I would talk about CHA2DS2-VASc score and has bled. So these are some risk calculators. You can find those on MD Calc or just Google. There are loads of calculators online. So CHA2DS2-VASc, it's based on age. You get 2 points if you're over 75. You score a point if you're female. So I'm afraid that's just fact of life. If you're a lady, you're at slightly higher risk of stroke than men. It's not perhaps as big a risk factor, for example, as diabetes, but for simplification, the CHA2DS2-VASc score counts both as one. A history of heart failure, so that's just of symptoms of heart failure, and it's not an echo showing left ventricular impairment. It could be heart failure with a preserved ejection fraction. Hypertension, previous stroke scores you 2 points, and vascular disease, which could be cardiac or peripheral. If we come over to the has-bled score, that, if you've got currently uncontrolled hypertension, scores you a point. So you might score a point on both, but you'd score a point here for hypertension history, and you wouldn't score a point if your blood pressure was now controlled over here. Renal disease, liver disease, stroke will get you a point here, but you'd still be net positive because it would get you 2 points over here. Prior bleeding, labile INR, elderly, which again might cancel out, but once you're over 75, you'd still be net positive. Medication use and alcohol use. Now, a useful way of using these scores is if you calculate the patient's has-bled score and their CHA2DS2-VASc score, and you subtract one from the other, and you're still left with a positive, i.e. your CHA2DS2-VASc score is higher than your has-bled score, then you should anticoagulate the patient. Great, so that's everything I wanted to say about atrial fibrillation. I hope that's all made sense. Have you got any questions at all? So the main point here is anticoagulate, rate control, echocardiogram, address risk factors, and if they're asymptomatic at that point, you do not need to try and restore sinus rhythm. They can happily carry on in their atrial fibrillation for the rest of these, unless you feel that they are symptomatic or that they're biologically young. So if you've got patients who are, I wouldn't have a strict cutoff, but say they're under the age of 50, they should have restoration of sinus rhythm at least considered, even if they're asymptomatic. So question, in patients with heart failure, how do you assess risk of decompensation in heart failure when starting a beta blocker for atrial fibrillation? Yeah, so that's a good question. Always think what could be driving the atrial fibrillation rate. So if you've got somebody in heart failure and who's also happens to have atrial fibrillation, very often they'll go fast because they're sick, and we need to address their heart failure rather than the fast AF. If their rate's very fast, so say they've got a rate of 180, then that I would be more concerned could be driving the heart failure, as opposed to a rate of say 130, in which I'd be pretty confident that the rate wasn't driving the heart failure. If they've got a history of heart failure, usually the fact that their rate is much better will help them. So actually giving the beta blocker might suppress cardiac output, but they're net to the good because their rate is now better controlled. If I was unsure, I would think about giving a short-acting beta blocker like metoprolol, or I would think about, if I'm really unsure, giving intravenous esmolol. So we got that on CCU. They also have it in A&E. Esmolol is great because it lasts for a few seconds. So you start the infusion, and if you achieve rate control, you carry on at that rate. And if they then go into decompensated heart failure, you can just stop it. Or if they're whatever the deterioration, you just stop it, and it's out of the system in seconds. So combination of heart failure and fast AF is a really difficult one, but by and large, if their rate's fast, say it's over 150, then I might think about starting bits of beta blocker. But the first thing I would do is diurese a patient who I knew had heart failure. So next question, I've often been told when managing acute AF in patients secondary to an underlying cause, e.g. septic patient, beta blockade should be avoided due to the risk of causing hypotension. The advice is usually to treat the underlying cause rather than to treat the rate directly. What do you think about the management in these situations, e.g. septic patient, new AF, fast feed rate? So absolutely, agree with that entirely. So that's I hope what I sort of got across to you with that first case where you've got a patient who's gone into fast atrial fibrillation, and while if you can rule out other things, you might well end up saying that it's due to just the stress of surgery, for example. But if it's due to sepsis or another condition, maybe that heart rate is the patient responding appropriately to a stress. Rates of over about 130, and you don't gain cardiac output by the faster rate. So I would still be wanting maybe some gentle rate control, but you absolutely should be treating the sepsis. Maybe they need their rehydrating in order to slow their rate down. With fast AF and decompensated heart failure, usually they have borderline BP, especially being offloaded with furosemide. Would it be a better idea to load with digoxin rather than a beta blocker? Yeah, so that's a great question. So does everybody think we should do that? Shall we have some quick votes? And does anybody think we should give IV digoxin so that it gets in fast? Or would you rather give some oral digoxin? So the problem here is that heart failure and fast AF, it tends to be that it's being driven by catecholamines, and digoxin isn't much good at controlling rate when it's driven by catecholamines. So giving digoxin to somebody with fast AF and decompensated heart failure is usually going to make you feel better that you're doing something, but it's not going to make the patient feel better. The IV or oral is a trick question because the oral bioavailability of digoxin is excellent. So unless the patient is so sick that they're not going to absorb it from their gut, it's absolutely fine to give orally. If they're so sick that they're not going to absorb it from their gut, you do not want to give it IV because you have to give it in a litre of fluids. So you're half a litre of fluid. So you're going to overload the patient even more. I wouldn't say patients with decompensated heart failure usually have borderline blood pressure. If you're in pulmonary edema, you usually have high blood pressure. So either you've got high blood pressure or you're going into cardiogenic shock, and that's a world of pain and hurt and very, very difficult to manage. I would, in fast AF and pulmonary edema, treat the pulmonary edema first. That's going to be your primary objective. You can rapidly get the patient to respond to furosemide, and that should bring down the rate, but then start to think about giving bits of beta blocker to bring down the rate, and maybe metoprolol or maybe esmolol in that sort of an instance. Wonderful. Are there any more quick questions or should we sign off? Great, some more. So I mentioned that a rate of 130 for a couple of days would be acceptable. What rates for how long should we be accepting? In situations such as the above in an asymptomatic patient, how long is it safe to wait before giving something to bring down the rate? Ooh, so these are questions that nobody can give you an absolute answer to because nobody's done the research. But typically, we not uncommonly see patients coming to hospital with decompensated heart failure and fast AF rate of about 150, and they've probably been in it for a month or two at rate of about 150, and that fast AF has slowly caused the ventricle to fail. And often if you can control the heart rate, the LV improves, but sometimes it doesn't. So certainly I wouldn't be comfortable you being rate of 150 for a month or two, but how long it takes is one of those you don't know the answer to. It's always the patients with asymptomatic fast AF that present with decompensated heart failure due to the fast AF. If they were aware of the AF, they would have come to their GP complaining of terrible palpitations and had it controlled and wouldn't have got the heart failure. Rates of about 130, that sort of a rate isn't likely to cause a cardiomyopathy in the short term. So I'm not saying leave the patient at that rate. What I'm saying is you can be comfortable to be addressing the underlying cause like sepsis. You shouldn't be trying too much harder than that. So yes, once the rate's down to around 130, I get much more relaxed about it. Rates of 150 plus, I would prefer to slow down. So waiting for fast AF without intervention, is this not a risk for a tachycardia cardiomyopathy? So I would say no. I would say that if the patient has known heart failure, then I would certainly be concerned. But if they've got a normal heart to start off with, they will be okay to be in fast AF for 48 hours. But why would you leave them in fast AF for 48 hours? If the AF is the only problem, then we ought to be rapidly addressing the problem. What we're talking about here now is the patient who's critically unwell with a pulmonary embolism or sepsis, and that's what's driving the fast AF. We're hoping to fix the underlying cause, and having addressed as best we can the underlying cause, we hope to see their rate coming down, and we might then want to slow their rate down to around 130 and maybe slow it a bit further. But these are the sort of patients who need to be on an HD or maybe even an ITU bed. That's, if you speak to an intensivist, they're not going to be trying to drive the heart rate too much lower than that because they want the higher cardiac output to help them deal with the acute, very severe illness. Good. Does anybody want to ask any more questions about that? These are some really, really good questions that have been coming through. Thank you very much for those. Great. Well, thanks a lot, everyone. Take care, and I'll see you all next week, and we can talk about ischemia. Thank you very much.